met all of you. I've taken call with some of you so far. Welcome to the division. We're excited to have all of you. Today I had a pretty broad topic. Acute kidney injury is a big part of what we do, and we have certainly learners of different levels of expertise even within our fellows. So I wanted to focus this on two different things. Um, to review the classification and the workup. Kind of the fundamentals of how we approach an AKI consult, even when what clues to look at, what you should be doing for those who are early learners, and then those who are later learners in nephrology, go over some of the literature regarding hemodialysis versus CRRT, and looking at different aspects of AKI management and what some of the literature shows. So just starting broadly, AKI is incredibly common in the hospital, 5 to 10% of hospitalized patients, and up to 60% of those admitted to the ICU. So, of course, as nephrologists, we know this that the prevalence is pretty high because our pager is always going off. But the challenge with AKI is it's not a uniform thing. There are a variety of causes that can involve different parts of the kidney, whether it's the glomerulus, the tubules, and you want to try to look at clues to decide where the injury may be based on the pattern of injury. So defining AKI, though we know it when we see it often, actually nailing it down has been a huge challenge for researchers and those who want to study AKI because it's so amorphous in a sense. A lot of the challenge is what is a baseline creatinine? We kind of eyeball a certain set of numbers and then we come up with a baseline and we say this is definitely higher than what it's been, but quantifying that can be a huge challenge. So most of these consensus definitions were developed mostly for research, but they do have some practical applications, so I think it's useful to go over them. So these are the three main ones, Rifle, Aiken, and KDIGO. KDIGO is more of a hybrid. I think if you want to commit one to memory, I would commit KDIGO to memory. And there are two classifications for urine output. There's urine output classifications for all three of them. And then the other portion involves the serum creatinine. If you're getting two different stages based on your urine output and your creatinine, you should go with the one that goes with the lower stage. So KDIGO, serum creatinine, 1.5 to 1.9 times baseline over 7 days, or greater than or equal to a 0.3 milligram per deciliter increase in 48 hours is considered AKI stage 1. So, for almost all of these definitions, when you get that absolute increase in 0.3, then typically you're dealing with an AKI, especially if the overall presentation is suggestive of that. Stage 2 is 2 to 2.9 times increase from baseline, and stage 3 is greater than or equal to 3 times the baseline, or the absolute serum creatinine is more than 4, or you've initiated dialysis. So these are the three broad categories for acute kidney injury definition. Most of it has to do with change relative to the baseline. So you can imagine this becomes incredibly challenging in research projects because baseline creatinine is pretty challenging to define. But this is what they use for most research studies. And then urine output stages go with, basically the amount of urine that the patient is making in a 12 to 24 hour period. So, of course, GFR is the gold standard marker for acute or chronic kidney disease. But we have to be cautious with, the spit out that we get from the lab panel for the estimated GFR, especially when we're dealing with AKI, because you have to remember that this is not really useful when the creatinine concentration is not in steady state. You could have ultimately almost zero GFR, but it's going to take some time for that, calculated GFR to get down that low. So on day 2, you may be dealing with an absolute GFR of 0 on a patient, but your calculation may not reflect that. So always be aware of that. That these calculations cannot really be used when you're not in steady state, as in AKI. So again, another challenge is to know what the creatinine clearance is at that moment accurately. In general, there are challenges with using serum creatinine in AKI, and this has kind of led to a lot of developments, or a quest for developments for biomarkers. I don't know that we've gotten to the point where we have anything that I've seen that rivals serum creatinine, in a way that we could use it efficiently and kind of methodically, but hopefully that's on the horizon. I know they've been trying for a long time. But there are challenges with creatinine as a marker of GFR. And one of them is, in acute illness, you're going to get reductions, and especially if you have sarcopenia or very poor muscle mass. So one thing you can do to get around that is cystatin C for the estimation if the patient has low muscle mass. Cystatin C is thought to be more accurate in that setting. And we actually have cystatin C available in our hospital. We used it on one patient last year in clinic, where we thought the serum creatinine may not be accurate. The other thing is, there was one of my attendings from fellowship, Kathleen Liu, has done studies on creatinine dilution during volume overload, and actually came up with a formula to correct the creatinine when the patient is severely volume overloaded, because you will get an absolute dilution in creatinine with volume overload. So another challenge in using creatinine, but for now we use it, and we use it often every day. But you do have the availability to get a cystatin C if you think that that's helpful. The caveat is cystatin C will have the same problems with an AKI, because to use that accurately, the patient does need to be in steady state as well. So it doesn't help you with that portion. As I mentioned, there's been just this tremendous effort to come up with a new biomarker. Most of the studies have shown that creatinine is a relatively late indicator, after the injury has occurred. So the goal is to try to find a marker that occurs that is abnormal earlier, the renal troponin. And there have been a lot of candidates, NGAL, this KIM1, kidney injury molecule 1. They've studied a lot in Boston, interleukin 18, and the liver type fatty acid binding protein. I'm not going to go through all these in details because they're still more or less in the research phase as opposed to the clinical phase. But one that actually has been FDA approved is the kidney stress biomarkers, the TIMP2 and the insulin-like growth factor binding protein 7. And these have been approved by the FDA for identification of patients at high risk for developing KDIGO stage 2 or 3 during the next 12 to 24 hours. So this is commercially available. I haven't used it myself personally. I know Dr. Sachdeva has strong interest in biomarkers as well. Maybe after the talk, he can share some of his experience with that. But I want to mention that this is at least one that is FDA approved for use.
Just to chime in on that, Dr. Scott, he's one of the critical care guys here. The NephroCheck has been approved only in the critical care setting. And Dr. Scott is really interested in running a study here. He has a grand round that is scheduled for, I think, August, where he's going to go over the design of that study and include certain patients and define them and compare the outcomes on those patients. And they really want to focus on cost savings in terms of whether use of this tool in patient care may help lower the cost of subsequent care for these patients. If we can avoid progression of AKI, perhaps you can avoid need for dialysis in some of those patients.
So just looking at the fundamentals of how we approach a patient with AKI and the value of history taking and chart review cannot be overstated. I mean, that often gives you strong suggestions, if not the answer, as to why the patient has developed AKI. So that in conjunction with your physical exam are really at the core of the workup. Of course, there's, a patient post CABG is pretty strong suggestion that, the AKI may be related to bypass itself. We see obviously tons of patients in that who go on the, cardiac bypass that develop ATN. The patient's hypovolemic with diarrhea and they're not eating, if they're a known heart failure patient who comes in with exacerbations, if they're developing shock, if you notice cholesterol emboli, these are all clues that the historical element gives you a lot of information. And with AKI, excuse me, sorry. All right, I'm back. I hope nobody called 911. So always looking at the temporal pattern of AKI is important. When looking at the AKI itself, I had one attending who became frustrated in fellowship with a medical student who was presenting an AKI presentation, and he summed it up with, somebody's killed the kidney and your job is to tell me who it is. So you're looking at the clues in that way. You're looking to see if there's hypotension, if the patient got contrast exposure, if something happened. And I think the best way to do that, for the new fellows is to look back at when the AKI event occurred, going back, because sometimes we get consulted very late. It'll be 6 or 7 days later. And when you look at when the increase in creatinine occurred, go back and look very closely in that 24 to 48 hours to see what changed. I mean, that's the thing you want to identify. Was a new medication started? Look at the vitals at that time. Was the patient hypotensive at that time? Did they develop a fever at that time? And then 2 days later, the blood cultures came back positive. So it's really important to look at the temporal pattern, and that gives you a lot of it gives you a big clue as to what may be underlying the AKI. And then rarely do we get a lot of suggestion from the physical exam, but sometimes you may see something like livedo reticularis in conjunction with lab findings like eosinophilia, and think of something like a cholesterol emboli. Physical exam, of course, is critical in assessing volume status. If the patient looks, has dry mucous membranes, has a history of poor PO intake, JVP is flat and all these things, of course, it'll clue you into the possibilities. And then also, there have been times where there's been some suggestion or some conflict with the presentation. Oh, the patient wasn't eating well, but you go and examine the patient and they have 3+ edema and pulmonary edema, you're going to it's going to influence your differential diagnosis. So urinary indices can be helpful, but there is a lot of controversy recently. If the patient is oligoanuric, then there may be some utility. There's definitely limitations in critically ill patients. And more recently, when they've looked at these types of laboratory tests, they've actually found that they don't perform very well. Some of the more recent looks at this have kind of identified or broken them into those that perform okay at times, but when they perform badly, they perform very poorly. So I think the key is you could use it possibly as a suggestive tool, but I wouldn't hang your hat on it. A lot of medical students are taught this early in medical school that, you start with a FENA and your entire workup is based on the FENA. That's simply not true, and oftentimes can be misleading. So your best bet is to do a really good physical exam. Now, is that easy? No, they've actually done formal studies using objective measures of volume status with physician examination, and they don't always correlate well, but really you want to do a good physical exam and try to identify the volume status of the patient and use that. In contrast to the urine studies, urinary microscopy is incredibly helpful, and you should really be performing microscopy for every AKI consult that you get. We have the lab open, we have a microscope, we have all the equipment to be able to do that, and it provides actually an excellent amount of information. And even if you know that the patient is, in sepsis, this is very likely ATN. There, there are actually studies. There's one study out of Yale looking at, the density of the muddy brown cast in terms of recovery, AKI recovery, and how that's a poor prognostic sign as opposed to sparse muddy brown cast. To me, it gives me some prognostic information. And sometimes you're just completely surprised. Sometimes, you'll bet that the slide will be full of muddy brown cast, and it's actually totally bland, and it helps you kind of refine your differential diagnosis. So really, urinary microscopy is, they call it the poor man's biopsy, and it's something we should, as nephrologists, be routinely doing on every AKI case, because it gives so much information, and it's non-invasive, it's cheap, and it's pretty quick. So you can grab a bunch of urines and do them all at one time. So yeah, this is definitely encouraged on the consult service. Don't wait for the attending to ask for the urine. Just grab it as part of your routine evaluation of the patient, and we can always take a look at it together. So like I said, urine sediment is a routine part of the investigation. Of course, if you're suspecting a GN, you want to see if they're dysmorphic RBCs or RBC casts. We've picked up white cell casts in patients that we suspected AIN in. So, I mean, it's just always good practice to see as many urines as you can. And then, of course, indications for kidney biopsy. Certainly if you have proteinuria, if you have nephrotic range proteinuria and you don't think it's diabetes, and you don't have a reasonable explanation of what it is, you want to consider a kidney biopsy. You have active urine sediment, and it is okay to biopsy a kidney even in the absence of significant proteinuria if you have no really good reason for why this patient has AKI. And there have been times where we've seen this kind of rapid progression, worsening AKI. The patient may have diabetes, but their last A1C was like 5, and they've never been on any they're just diet controlled, and it really doesn't match the picture. It's okay to do a biopsy if you as the nephrologist are not comfortable with why the patient has AKI or chronic kidney disease. Usually we reserve it for when it's progressive and getting worse, but that is an indication for a kidney biopsy. So one of the causes of AKI that's underdiagnosed in the hospital is acute interstitial nephritis, mostly because it's just so challenging to diagnose. You don't usually see it paired with the classic symptoms of rash and eosinophilia. That's usually 10% or fewer of cases of AIN. So really, your index of suspicion has to be incredibly high. We have patients on PPIs left and right, and antibiotics, it's always challenging because is there an underlying ATN from the infection? Is it the antibiotics itself? It's a very tough diagnosis to make. A lot of people hang their hat on urinary eosinophils. If it's positive, of course it's suggestive and would clue you in, but if it's negative, that really doesn't rule out acute interstitial nephritis. And to make for a definitive diagnosis, you should perform a kidney biopsy, but you don't have to perform it in every patient you suspect, especially if it's mild or it's improving with withdrawal of the agent. But if you are absolutely making the diagnosis, then you want to pursue kidney biopsy. And of course, the first line treatment is cessation of the culprit medication. And then if it's progressive or not improving, you would consider steroid therapy as well. So the role of imaging in AKI workup, kidney ultrasound is a non-invasive test that can provide information. So consider getting a renal ultrasound in patients with acute kidney injury, especially if they have concerning features such as a history of BPH, any sort of malignancy that, could cause problems with the ureter, should clue you into obstruction as a possibility. But sometimes you just see obstruction without these risk factors as well. To cause AKI in a patient with two functioning kidneys, the obstruction should be bilateral. But just remember that a patient can be non-oliguric and can be obstructed. That's one thing that I've noticed some people incorrectly assume that for the AKI to be obstructive, that the patient should be oliguric, and that's not always the case. I mean, some of it has to do with pressure in the system. So always keep obstruction in the back of your mind in terms of your differential. So AKI is a huge topic. I mean, I could literally spend a week talking about each of these disorders, but it always comes down to the big three categories that you learn in medical school that every medical student can recite, which is this, pre-renal, intrarenal, post-renal causes. And really that holds true even at our level. That's what we're thinking of in terms of what's going on. So, putting all these things together, if you're seeing a patient in the burn unit that's having incredible insensible losses, you would think hypovolemia, or if you have a history of poor PO intake. You can see a cardiorenal phenomenon with poor perceived blood flow to the kidney related to poor cardiac function with heart failure. But sometimes, you always have to keep these things in the back of your mind. We had a really fascinating case on Team 6 last year with a patient that had AKI for unknown reasons. He was transferred to our team from an outside hospital with blood pressures in the 80s. We did a pretty extensive workup until we suspected, maybe this guy has cardiac issues, and we got an echocardiogram, and he had this massive pericardial effusion with tamponade. And they drained the effusion, and his creatinine went from like 4 to 1. I mean, it's incredible. So always keep this gigantic, slide in mind when you're thinking about your differential diagnosis for AKI, and always move things up and down depending on the clues that you're given or that you get. Of course, there are medications that can cause issues. I'm going to talk a little bit more about that in detail. Electrolyte abnormalities such as hypercalcemia, that it can induce a diuresis and cause pre-renal disorder. Hepatorenal syndrome is a syndrome of also perceived decrease in blood flow based on splanchnic vasodilation, and there are different theories for why that occurs. Compartment syndrome in our patients that are post-op or have ascites, and those with systemic vasodilation. Then intrarenal causes, that's sometimes, when I ask some early learners on our team, like what they think the cause of the AKI is, and they say intrarenal. I mean, that's a huge category, but these are things that you should keep in mind. You can break it down into vascular problems that typically come with some degree of hypertension as well, refractory hypertension, microvascular. Sometimes the clue is thrombocytopenia, or related history of scleroderma or preeclampsia. And then, of course, our big kind of most fascinating one that entertains most nephrologists is the glomerular category. And of course, your your hematuria and your proteinuria will kind of clue you into that that characteristic of renal pathology. Then we have our tubulo-interstitial diseases, including AIN, rhabdo, the patient that's found down, or had major trauma. When you're called to the SICU to see a patient, always make sure that you're ordering a CK, especially if there's some trauma involved. And then ATN is going to be the most common cause of in-hospital AKI. So lots in the tubulo-interstitial category. And then finally, post-renal causes, if the patient has BPH, cancer, history of strictures, they're passing clots. These are all things that should clue you in. And we definitely work hand in hand with our urology colleagues and interventional radiology to assist with decompression, but trying to identify the need for decompression is an important part of the AKI workup. So I think this is a pretty good table to just kind of keep in mind, especially for our new fellows that are starting. Our interventional ones are probably pretty familiar with this list, but for our new fellows, just kind of keep this list in mind, and every AKI you see, try to find out where they fall into this list, and try to find out what clues you need to feel comfortable that they're not in one or in another. And that's really what we do on the console servers. That's what we're doing. That's probably 3/4 of the work, and then another quarter is figuring out what to do with the AKI and whether they need dialysis or what therapy will assist. So medication review is really critical and an important part of the workup of AKI. And it's twofold. One is you're looking for medications that may have caused the AKI or contributed. And then the other reason we review the medication list is, now that the patient has the AKI, are we dosing medications correctly? So in terms of looking for nephrotoxic agents, you want to see if the patient was on NSAIDs, if they had a community use of NSAIDs and now they're coming in with diarrhea, and you're suspecting an ATN because of that. If they're on an ACE or an ARB, and how that has influenced the progression or their presentation. Certainly you want to be cautious with gadolinium, because patients with advanced chronic kidney disease are at risk for NSF and really bad complications. So keep an eye out about what the primary team is doing, because they'll do this sometimes, and technically the radiologists are supposed to protocol these tests, but it doesn't always work out that way, and sometimes they can slip by. So you always want to make sure that you're looking at what the team is ordering. If you see an MRI with contrast, you need to check the GFR and make sure it's suitable to receive that study. Certainly if it's under 30, you want to caution the team and also put a stop to things until you have a extensive discussion with the team and the patient and everybody, and often the radiologist as well. Iodinated contrast is always something you should look at. You want to look at all the imaging studies, see if the patient got contrast, and see if it's temporally related to the AKI event. If they got contrast, a week and a half ago and the AKI event occurred now or a day ago, it's unlikely related. So, the time component is important there. And there's been a renewed interest in the nephrotoxic effects of antibiotics, especially vancomycin. Some high-level microscopy actually has shown some nanospheric vancomycin within tubular casts. Especially, and the risk really goes up when the levels are very high or greater than 50. So I personally have always felt that Vanc gets probably more attention that it deserves, because usually there's an underlying infection, but it is certainly a consideration that to consider that. And there is some suggestion that Vanc plus Zosyn may actually potentiate the nephrotoxicity, but these are still suggestive and haven't been borne out in any trials of any kind. So the medications that, if you're getting a new consult and you see one of these meds on the list, your antenna should go up certainly as a possible cause of AKI, because these are medications that are associated with acute tubular necrosis, especially your aminoglycosides and your amphotericin, which is sometimes referred to as amphoterrible, because some infectious disease doctors think that it actually isn't working unless your creatinine is going up. So keep an eye out for that. Cisplatin on the hemonc services, Foscarnet, tenofovir. These are all medications that have a bad rap with the kidneys and should alert you that they could be contributing to the AKI itself. So this is a list that you should start working to commit to memory, because this comes up a lot, and this is a big part of what we do as nephrologists, is trying to identify medications that are renally cleared and may cause problems to our patients. And I can't stress how important this is. I've seen patients with adverse effects from a lot of these medications. Gabapentin is a big one because so many of our patients are diabetic and have neuropathy, and oftentimes the dosing exceeds what is recommended. I've certainly seen dialysis patients become somnolent from gabapentin, so be aware of that. Demerol, I can't tell you how many times I've canceled the post anesthesia orders that give Demerol for shaking or chills in ESRD patients. You certainly don't want to give that. You have to be cautious with the dosing of antivirals like acyclovir, any sort of antimicrobial dosing. I feel like most of us are more tuned to that than, and even the primary care or the primary teams or primary care physicians, when they're prescribing antibiotics, are kind of more aware of renal dosing than the other ones. Diabetic agents, you'll get these ESRD patients that come in very hypoglycemic from sulfonylureas, so you want to be aware of the dosing of that in patients that you're seeing. And I've seen it 2 or 3 times now where one of our ESRD patients come in with bicarbs of 6. Their community physician decided that they should be on metformin for their diabetes management, and they come in with this life-threatening lactic acidosis. So again, I see it as part of our role to make sure that that patients that we're following aren't getting medications in the incorrect amount. Baclofen, I've certainly seen more than one patient being hospitalized for baclofen toxicity. Colchicine is a big one that you give these very, very, very small doses, sometimes as low as 1 dose per week, because the patients can get symptoms from toxicity. Digoxin is a big one. If you ever see a patient with abnormal renal function receiving digoxin, you should make sure that they're getting levels. I've actually heard of a case where a patient was in a rehab center, started on digoxin, didn't check the levels, the patient coded and arrested. You don't want that happening to your patient. Low molecular weight heparins, there is a very significant warning for use of these, against use of these in patients with ESRD for full dose use. So I avoid them altogether. The low molecular weight heparins in patients with ESRD or those with AKI and dialysis. And then some of the NOACs, you have to be just aware of the dosing. So this is a big part of nephrology, is looking at medications. Not to say that you have to know them all by memory, but I would become familiar with the ones that do need to be adjusted. So when you look at the list, it kind of triggers it. If you're not sure, just check up-to-date renal dosing, and that's the easiest way to do it. But it's good to be aware of these medications that can cause problems for patients with AKI or ESRD. So now looking at the management of AKI and different approaches. So IV fluids are very commonly prescribed for any AKI event, especially on the surgical services. Despite, IV fluids being appropriate at times, early goal-directed therapy in sepsis didn't have any effect on the need for renal replacement therapy in 3 large trials. And several retrospective studies have found an association between positive fluid balance and mortality on critically ill patients. So the key is you should see if you think that your patient may be volume depleted and needs IV fluids in terms of their renal function, it's okay to start the fluids. But if you're not seeing a response, and you don't think the patient is volume depleted, then you may want to think about whether it's worth your while to continue the IV fluids, especially if your patient's oliguric already. And I see this mistake being made on some of the surgical services more than the medical services, where the patient has an AKI event. It's likely related to ATN, but surgeons see so much pre-renal AKI that we're not consulted on, so we're kind of biased towards this approach. But they see so much pre-renal AKI from blood loss that their immediate response is to give fluids, and oftentimes that does take care of the issue. But sometimes we see this pattern where they give the fluids and the patient's creatinine is still going up, and then instead of kind of stopping the fluids, the rate starts going up, or they'll start bolusing because they'll say that the patient needs more fluids. So just be aware of that phenomenon, because the last thing you want to do is to push somebody into pulmonary edema who maybe wouldn't have needed dialysis if they had time to recover on their own. So the trials looking at composition of the fluids that you give somebody in AKI was assessed in 2 trials in the New England Journal of Medicine. So this was a table from a review article that Dr. Amin, the other Dr. Abreu, and I were involved in. And it's looking at these 2 trials, the SMART and SALT ED trial. And these were designed very, very similarly, but one was looking at the ICU population, one was looking for the non-ICU population. And they looked at mortality for those receiving a balanced crystalloid versus saline. So saline theoretically is high in chloride and can lead to an acidosis. And the genesis of these trials were that there's a possibility that there may be higher mortality in those receiving saline. So when they looked at overall mortality, there was no difference in mortality between those receiving balanced crystalloids versus saline. But when they looked at this composite renal outcome, which was which was new renal replacement therapy, or persistent renal dysfunction, and then when they had this aggregate outcome, they found that the risk of major adverse kidney events within 30 days was not the same between the 2 groups, and there was a slightly higher increase of these adverse kidney events within the first 30 days in those who received saline versus the balanced crystalloid. Now, again, this is the absolute clinical difference, is about 1%, so it's not a humongous effect size. But all things being the same, it gives us some pause to consider balanced crystalloids in this situation for patients with AKI. And I think most of these were sepsis AKIs. So in that context, to consider balanced crystalloids. Then there was another trial in the New England Journal of Medicine looking at saline versus albumin and seeing if mortality improved or if there was a renal benefit to those who received saline versus albumin. And they found that these ICU patients who received saline and albumin had similar renal outcomes and similar mortality outcomes. So there was really no benefit. The one benefit that you could gather from this was that it took less total volume for resuscitation in the albumin group. So the ICU a lot by giving albumin to patients that they're concerned for that they may develop volume overload. So you can get some more bang for less of a buck, I guess, by giving albumin. And here's the overall survival curve. So there's no survival benefit in giving albumin versus saline, but again, it wasn't worse. The next trial in terms of AKI management was the sepsis spam study looking at blood pressure targets and in patients on pressors in the ICU and whether to target higher or lower targets. And one was looking at the target was around 80 to 85 and the other was around 70 to 75. This was kind of how the actual numbers broke down. And they found in terms of survival that there was no difference in terms of survival between the low target group and the high target group. So no mortality difference, but one interesting fact was when they looked at the subset of patients with chronic hypertension, the higher MAP group had significantly lower rates of AKI and renal replacement therapy. So there may, in general, you should probably consider, the patient's premorbid blood pressures when you're trying to decide on a goal in terms of pressor therapy. Because even though you may have similar mortality outcomes, you may be stressing the patient's body out more theoretically if you go too low with your target. And then next is the role of diuretics in AKI. So of course we use loop diuretics a ton to prevent volume overload. And theoretically there is some theoretical benefit that there's an attenuation of the ischemic tubular injury by decreasing metabolic demand in the medulla. But I mean, I don't know if that's totally borne out in any sort of clinical trial. Clinical trials haven't shown any benefits of diuretics in patients with AKI. That's not to say that there's no use for them. So KDIGO recommends against the use of diuretics to treat the AKI unless you're trying to actually treat volume overload. So again, the diuretics don't really help in terms of improving the AKI, improving a blanket AKI. I think you could make an argument if the patient's cardiorenal, that's a different story. But but it's still okay to use diuretics in the setting of volume overload, and of course, we use them frequently. Finally is nutrition and glucose control. AKI is a catabolic state, so you want to make sure that the patient's receiving adequate nutrition. We always prefer the enteral route because of its lower risk of infection. If you look at the KDIGO guidelines, they recommend maintaining blood glucose concentrations in ICU patients between 110 and 149, and a lot of that is derived from the NICE sugar trial that showed that patients with lower glucose goal of 81 to 108 versus a goal of less than 180 actually had higher mortality, but there was no difference in the rates of RRT between the two groups. Okay, so now I'm going to kind of switch gears and focus a little bit more on looking at the topic of intermittent hemo versus CRRT and what the literature shows on that. So there has been a Cochrane meta-analysis looking at this, and they did find that there was more of a hemodynamic benefit to patients on CRRT, and this was, they theorized that it was related to heat loss or hypothermic effects that's actually leading to, increase in blood vessel tone and higher blood pressures, but they didn't find any difference in survival between the two groups, between critically ill patients receiving CRRT versus intermittent hemo. And there are always going to be design challenges with these types of studies because there's kind of a knee-jerk reaction to avoiding intermittent hemodialysis in those who are critically ill, and also excluding patients who are, the most severely ill in these types of trials. So there's always going to be some sort of selection bias and some sort of exclusion bias. But on the whole, these results are pretty consistent, and we'll take a look at the literature. So what is the advantage of using CRT? In one RCT, but not another, CRT allowed for more negative fluid balances. And I do believe that fluid overloaded patients can benefit from CRRT, especially if there's something where they have this insanely high obligate intake of 5 to 6 liters per day. It's just hard to keep up with those types of fluid balances, even with daily dialysis. And especially if the patient is hypotensive, you know, there's only so much you can do with intermittent hemo. So out of all the reasons, you know, in my practice, I feel the most compelling reason to transition somebody to CRT is really a very high obligate intake. The patient's requiring TPN, or they are requiring all these infusions. They're on multiple pressors that come with a high obligate intake, and it's really hard to keep up. In that situation, you know, you would want to consider a CRRT in that patient. When they looked at preservation of renal function, they didn't find actually any benefit. You would think that you would have, you know, the theory is that you have less hypotension, so you're perfusing the kidney better, and that you're able to recover from AKI sooner with CRRT. But that didn't really bear out in studies. So nearly all the controlled studies and meta-analyses do not demonstrate any improved preservation of renal function in CRRT versus intermittent hemo. There was some thought that maybe in sepsis, particularly, that using CRRT could remove some of these cytokines through adsorption on the membrane. But the challenge with that is, even once the membrane surfaces are saturated, you're really not going to get much more removal beyond that. So I don't know that. And the other thing is that you're removing pro-inflammatory cytokines just as much as anti-inflammatory cytokines as well. So I don't think that this is a very compelling reason for using CRRT. And you know, there has been no real survival advantage, as I mentioned before, with more efficient solute removal between the two modalities. And one thing you have to consider is that CRRT can have frequent interruptions. You know, in one study, they looked at the how much time the patient was actually on the machine, and the average was 19.5 hours, but some patients were receiving as few as 13 hours of delivered therapy. Another very compelling reason to consider CRRT, or at least significantly reducing your blood flow rate, is intracranial hemorrhage. So hemodialysis itself can increase intracranial hypertension and can worsen some of these intracranial bleeds. Continuous modalities are associated with better cerebral perfusion. So if you are doing hemodialysis, make sure that you're decreasing the blood flow rate. And this is a study that looked at ICP monitoring in a patient receiving hemodialysis. So you can see at the time level 8 to about 12 is when the patient was on hemodialysis, and you can see that spike in ICP. So that's what we're trying to avoid. So overall perceived advantages of CRRT: allows adequate volume of nutrition, allows the patient to get TPN without compromising fluid balance, decreases vasopressor requirement because you can remove fluid slowly, even at minus 25 cc's per hour, improve hemodynamic stability, optimizes fluid balance, and you have control of your fluid balance is a primary advantage. So this was another study in the ICU looking at continuous modality versus intermittent hemodialysis. I won't go through to all of the design considerations, but they were pretty balanced groups in terms of the makeup of the groups. And these were the characteristics. So in this trial, they were doing about 5 hours of dialysis at, a blood flow rate of about 278 versus a continuous modality. And there was, as I mentioned before, in this trial as well, there was no survival advantage at day 28, 60, or even 90. And no difference also in the renal support duration days. So that's just the survival curve. You can see no difference. This was another study looking at the same thing in a different population, showing no statistical improvement between one of the two groups. And then these are a number of RCTs that have been done exploring this. So really, overall, the literature kind of doesn't show an advantage to CRRT versus intermittent hemo on the whole when looking at these trials. So with that in mind, there is some practicality to using intermittent hemodialysis. You get to use a conventional machine. The patient isn't tethered to a machine 24 hours a day, so they can participate in rehabilitation. They advanced mobilization that's not possible if the patient's connected to CRRT machine. And you have the ability to observe, you can actually look for renal recovery more easily with intermittent hemo. You may be able to go a day without dialyzing the patient. You can look at that non-dialysis day, interval in terms of your creatinine, their urine output. A lot of that gets erased when you have the patient on continuous hemodialysis. There are bleeding complications. CRRT often warrants anticoagulation, so you can see challenges with bleeding. Citrate anticoagulation can lead to hypocalcemia. I mean, it's supposed to cause hypocalcemia, but then you give an infusion of calcium. But even despite that infusion, you're always trying to titrate to the calcium. So there are some practical challenges with CRRT as well. So intermittent hemodialysis with its higher blood flow rate provides more efficiency. And this is important for a patient coming in with hyperkalemia. So if your patient comes in with severe hyperkalemia, you don't want to, immediately do CRRT because it's going to take some time for that clearance. You want to try to, improve the potassium more rapidly than that. PERT is one of these hybrid therapies. It's essentially doing very long treatment, but not 24 hours. You may have a day shift, a 12-hour shift of doing PERT where you may use lower blood flow rates, but you're not doing the replacement therapy 24/7. And that allows you, but you still have an extended period of time where you can take fluid out slowly. But again, it's not a 24 hours a day sort of intervention. So yeah, the treatments are typically between 8 and 16 hours. Some equipment, you can do it with dialysis, a conventional dialysis machine as well. All right. So just at the very end, I just want to quickly go through the three mechanisms or the types of CRRT. Of course, CRRT is a general term. When we get more specific, there's CVVH, CVVHD, and CVVHDF. So with CVVH, it's continuous veno-venous hemofiltration. You have a high rate of ultrafiltration, and this is basically you have solute removal through solvent drag, and solute transport is occurring through convection and bulk changes of bulk flow of the water across the membrane. CVVH usually involves a replacement fluid, so you can give a balanced replacement fluid. One advantage is you can remove quite a bit of fluid this way, and you can titrate your replacement fluid to get that high ultrafiltration rate. And you can give the infusion either pre-filter or post-filter, depending on what you're trying to achieve. If you give it pre-filter, you'll dilute the solute content of the blood and you can reduce your solute clearance, but you may have better circuit life in terms of keeping the circuit going that way. And these are schematics that are helpful to me, you know, that where you can see that you can either give the replacement fluid pre-filter or post-filter, and then you just have the straight ultrafiltration. And again, this is a convective process. So CVVHD is you're doing dialysis, so you're using dialysate, so there'll be one big difference between CVVH. UF rates are typically low in CVVHD, and you don't need to use replacement fluid. So you're basically just using dialysate. You're using the countercurrent mechanism. You're using diffusion, and you do it this way. I mean, you're basically doing very, very slow hemodialysis is the easiest way to think about it. So you have an effluent, and basically you have the countercurrent exchange. And then the last modality is CVVHDF, which is a hybrid therapy combining, you know, CVVHD with CVVH. So this is where it can get a little bit confusing. So when you're writing the prescription, you know, you're going to be writing both a replacement fluid and a dialysate, and you're going to give flows for those things. So you're doing both things. You're doing dialysis, and you're also giving a replacement fluid. And the effluent is the ultrafiltrate, and this plus the spent dialysate. So diffusion provides efficient clearance of low molecular weight solutes, but if you want to clear higher molecular weight solutes, then you want to think about using something like CVVH for those in the higher range of molecular weight. And the dose is defined by the effluent flow rate. So the effluent is the waste fluid that comes out of the outflow port. And the minimum targeted dose based on trials is 20 milliliters per kilogram per hour. So usually you would want to write your prescription to achieve an effluent flow rate of approximately 25 milliliters per kilogram per hour. When they did big trials of looking at the prescription, when you have higher dose CRRT, there was no mortality benefit compared to lower rates. So that's why this 20 to 25 milliliters per kilogram per hour is the standard prescription rate. And that is it. Anybody have any questions or comments?
Great. I think this kind of will put our first year fellows in position to know how much they need to learn, and the whole spectrum of nephrology pretty much would be covered if you know all AKI at the start of your fellowship. So yeah, I think there's a lot to look forward to. Just a word about the urine analysis. In the last few weeks, I was inspired by Dr. Juan Carlos from Ochsner in New Orleans. He has been using this Sternheimer Malvin stain, SM stain, for his urine analysis. And if you're on Twitter and you follow him, you see all these beautiful images of urinalysis that he keeps putting out. And I got this stain about a couple of months ago, so it's available in our lab now. I found it that if you put it into the urine before you spin it, it really stains the cast really too dark. So you really don't need the contact time to be very large. I've been putting about half a drop into the final precipitate with a and get it on the slide. And some of those pictures look really beautiful. Like recently, we had a patient with acute rhabdo, and I was able to see clearly the heme pigment on the fine granular cast, which without the stain may have looked like a highline cast or otherwise, but with the stain, they clearly stained reddish. So use it. It's available here, and I think it's a great tool to really take some good pictures and put them into patients' charts so that consulting medicine guys can also look for themselves as to what they have. There was another patient who had a high uric acid and very high amount of urate crystals in his urine, and they stood out so beautifully with that SM stain. So thank you.
So I used it twice, but do you put in that tube, or I was putting on a slides? And
so
didn't color it well.
After I spin the urine, I put about half a drop. I drain the urine out, all the extra urine out. So you're left with, say, about a few drops of urine and the precipitate right at the bottom of the tube.
Right, that was usually we do.
So then about half a drop of stain into that. I shake it. I mix the precipitate and the urine together, and then put it on the slide directly. So, and within that minute of transferring that urine into the slide, you usually get really good staining of the nuclear.
Okay, so I was putting on the slide. That didn't help that.
If you put it on the slide, I think it gets too dark because it's really concentrated, and the pictures are becoming very, very dark. And I tried to bring it into the urine itself, and the cellular casts become too heavily stained, and you can't really differentiate between red cell or white cell casts.
Yeah, it become very dark, so I stopped.
There was the stain that I just did on a patient from the clinic the other day, and this lady had likely has vasculitis, and then those red cell casts are beautiful, and you could see the red cells very clearly with the stain.
So it's for casts or for everything? So is there any specific indication for use it, or?
I would use it on everything. It's just that you don't know what you're going to find on that stain, on that urine.
What is exactly for it? It's
it's going to stain. So it's going to stain the nuclei. So it'll help you differentiate between, say, the white cells, red cells really well. If this cast is a cellular cast, the nuclei will stand out really well. Yesterday we had a lady with a interstitial nephritis with likely interstitial nephritis, and she had white cell casts, and nuclei stood out beautifully within the cast. If you had not stained it, you probably would not have been able to differentiate the white cell cast with an RT cast as well.
Yes. All right.
Any questions from the fellows? We also have a couple of residents who are listening in. Audrey, Jasmine, and Devlin. Any questions, guys?
We don't have any questions.
Yeah.
Very clear, Doc.
Okay, good. This is going to be followed up with a workshop, a hands-on workshop for the first-year fellows and the interventional fellows on ultrasound-guided cannulation of vein. This is going to be up on the 8th floor. We cannot do it virtually, guys. So 8th floor, if the residents are interested, you guys are welcome to join as well. There's a model up there, a neck IJ model, and you'll use ultrasound guidance to use micropuncture wires to cannulate those veins, and how do you best avoid complications, and what are the tips that you can learn from two of our experts here, Dr. Amin and Dr. Sequeira, are going to lead that workshop today.
That's for the residents?
The residents, fellows, yeah, faculty are excused. All right, thank you, guys.
Thank you, Adrian.